Hi everyone. Now, today we will be talking about a very common topic. It is not something very special or something, but yes, it is important. So, we'll be talking about chorioangioma, which is a benign tumor of the placenta. And very often, when you are scanning, you should always be very careful that you scan the placenta carefully. Look at the placenta texture carefully, because many times these chorioangiomas may be very small, and as a result, you may miss them. And this often happens also, even despite doing your best, you may miss a small chorioangioma because it is too small to be seen. But the larger ones should not be missed because those are more important. Smaller one, even if you will miss, usually they do not create issues, but the larger one can create problems for the pregnancy. So first of all, it is yes, the most common primary tumor of the placenta. And then I've already told you it is benign. It is primarily composed of blood vessels and stroma. So primarily there are capillaries and there are angio. That is why the name angioma is there. And then there is stroma. So let's go to the ultrasound part. Now, what is the ultrasound picture that you will see in a chorioangioma? Usually you will see it like the most common picture that you will come across will be a well-defined round encapsulated hypoechoic mass, may have few cystic areas, and it will be very often near the cord insertion and towards the fetal side of the placenta. All these things help you, I'll tell you how later. So it will be well circumscribed, predominantly hypoechoic, towards the fetal side of placenta and very often close to the cord insertion. Then the vascularity may vary. Some cases may be avascular, some cases may be highly vascular, and high vascularity holds significance because higher the vascularity, more are the chances of complications. We'll discuss the complications a little later. So keep this in mind. See here, you can see if I go back, I'll just go back and put here. You can see the placenta and you can see the hypoechoic mass, which is very well defined, mostly homogeneous but has few cystic areas, and the capsule can be seen very clearly. It is towards the side of amniotic fluid, not towards the myometrial side. And then when we put color, let us see. This one is showing you reasonable vascularity. I would not say very high, but yes, there is definitely vascularity, and this is the cord area that you are seeing. So it is near the cord. You can see the cord area here, and then you can see the vascularity is there definitely, and it is inside also and at the margins also. Now, diffuse vascularity is there. And let us see what would be the spectral Doppler showing us. And the spectral Doppler shows that, see here, you can make out the pattern is like the umbilical cord pattern. So this tells you that it is a part of placenta only. The flow is very similar to the umbilical cord flow. Then what can be the differentials? Now I have put three pictures here. One by one we will see. This one you can see here again there is a hypoechoic rounded mass, but if you notice carefully, yes, it looks as if it is encapsulated. But what is the difference? It is not very well round. It has an irregular area here. The texture looks more heterogeneous. Still, you may confuse it. Yes, it is towards the fetal side. No, placenta is here, so it is towards the fetal side. So it may come to your mind that this is chorioangioma. But why this is, what is it? Actually, this was a blood clot. Now, what is going against chorioangioma? One thing that is going is that the texture is heterogeneous. Still, if you get confused, what is the way to differentiate? Then you can put color also. If it does not show vascularity, yes, the chances of chorioangioma may not be there, but still I have already told you that choriangiomas can be avascular. So now again there may be a confusion. So what is the better way to do it? If you are confused whether this is a chorioangioma or a blood clot, what you can do? You can follow up the patient, right? So this was actually a blood clot, and when we followed this up, it changed picture on, or it changed its appearance. Chorioangioma will not change appearance. After a week only, you will, if you will follow a picture where there is a blood clot over the placenta, the subchorionic hematoma is there, then if you will just follow after a week, it will show you changes. So while chorioangioma will remain same. Second thing, let us see this one, why we may say this is chorioangioma. Now this also looks like a well-defined, this also looks like a well-defined mass. No? It's a well-defined hypoechoic mass, little bit heterogeneous, few dark areas are there. But let us see why we did not take it as chorioangioma. Two things. If you will see in the very beginning, I'll just go back. See here. It is not towards the amniotic side. It is towards the maternal side. It is towards the myometrial side. So obviously, what is the first thing that comes to your mind? Well circumscribed mass towards the myometrium. And then when we put color flow, how does the color flow appear? Let us see again. See here. The color flow is at the periphery, which is telling you this is what? This is a myoma. Two things that were going against chorioangioma. First was that it was towards the maternal side. Are chorioangiomas present towards the maternal side? Very, very rarely. They are usually towards the fetal side. Second thing that was going against was the typical flow that you are seeing around the periphery, which is very typical of myoma, right? So again, that part is ruled out. Now the third picture is the video that I'm showing you is of partial mole. Now, how can you confuse partial mole with myoma, with chorioangioma? See, some cases of chorioangioma, the picture may be not what I showed you here. Some cases, the picture may be like this. Irregular heterogeneous mass with cystic areas. So these can cause confusion with partial mole. The partial mole also looks like this, and it is within the placenta. Then how can you differentiate between the two? Most commonly, what you can see in these cases, in partial mole, it will be more diffuse. No, the cystic areas will be spread out throughout the placenta. While in this case, they will be confined to one area. Then they will be more towards the fetal side of the placenta. Partial mole, the cystic areas will be spread out overall everywhere. Third thing, you may find a capsule, which will not be seen in partial mole. There will be no capsulation. No? You cannot see any capsule anywhere. And fourth thing that can help you, these areas, if it is a chorioangioma, many times it will show you vascularity. So vascularity, partial mole does not show you so much of vascularity within it. It may show you vascularity around, but less commonly it is seen, right? So this is an atypical appearance, right? So the confusion with partial mole will come only when the appearance is atypical, when it is not well defined round or it is little irregular. Then you may get a confusion with partial mole. Otherwise, partial mole will not be confused with chorioangioma. Now, let us go to, once you have diagnosed it, what next? After you have diagnosed it, remember, if it is small, usually these are asymptomatic tumors. Bigger ones may also be asymptomatic. So the thing is that small ones will not cause much problem. So what you have to do, you just have to keep a watch, do a follow-up and look for especially polyhydramnios. And then if there is the polyhydramnios developing, you have to be careful. I'll tell you what the reason why. But when they are large, then the problem may come more. Like complications are more when they are large. What are large chorioangiomas? More than 4 centimeter in diameter. Now, when they are large, what happens? It's a vascular tumor. It's having vessels. So what happens? There may be a high chance. Any tumor which has more of capillaries and arteries and all, there are high chances of arteriovenous shunts. And because of these arteriovenous shunts, you can very well know the blood will go from the venous side to the from the arterial side to the venous side. As a result, there will be right heart overload, there will be cardiac failure, and this will lead to heart drops. So that is one major complication that may occur. Then the vessels in these tumors are very tortuous. They are very tortuous. So because of the tortuosity of the vessels, what may happen, when the blood is flowing through them, it will get a lot of hindrances here and there, and this may lead to red cell destructions, platelet sequestrations, leading to thrombocytopenia, hemolytic, microangiopathic hemolytic anemia, and DIC. Because the clotting tendency will increase because of the obstructions to blood flow. Then, because of the mixture of the blood between the fetus and the mother, there may be feto-maternal hemorrhages, and that may lead to fetal anemia. Because I told you there are arteriovenous connections there. And then what happens? A part of the placenta will be non-functional. It will not be working well because there is a large area which is abnormal. So what may happen? The nutrition may become poor to the fetus, oxygenation may become poor to the fetus, and as a result, what will lead? It will lead to IUGR, intrauterine growth restriction. Now, most common problem associated with chorioangioma is polyhydramnios. Now, the reasons actually are not very clear, but two hypotheses are there. One is believed that since this mass is near the cord, this mass is going to, the mass of the chorioangioma is going to press over the cord, and as a result, there will be obstruction to the blood flow. Because of that, the transudation into the amniotic cavity may increase due to high intravascular pressure. Pressure in the vessels will increase, and this may lead to transudation of fluid into the amniotic cavity. Second reason they believe is that since there are lots of vessels on its surface, direct transudation may also occur from these vessels, because these are large vessels and they are over the surface of the tumor and the surface area is increased. As a result, this will again lead to more transudation. Other things that can be associated with antepartum hemorrhage and postpartum hemorrhage. Antepartum hemorrhage may occur due to premature separation of the placenta, as there is a big mass there, and bleed may occur and abruptio may occur, right? And then there may be sometimes, in some cases, choriangiomas are attached to the placenta by a pedicle, and that pedicle may rupture, and this may again lead to antepartum hemorrhage or abruptio. Postpartum hemorrhage, why it may occur? Because if the mass is very large, it is going to distend the uterus, and this may lead to uterine atony. Then, what are the other things that may be associated with chorioangioma? They may be associated with high HCG levels. Now, because what could be the reason for high HCG level? Maybe because of enlarged placenta, or maybe the chorioangioma itself secretes HCG. High HCG may again lead to what? Thecal lutein cysts. And then in addition, because of the feto-maternal hemorrhages, there may be increased serum alpha-fetoprotein also. These are the additional findings that may come in chorioangioma. But remember one thing, again I am repeating, small choriangiomas will not cause any issue. The pregnancy may go totally uneventful. But we have to be careful with the large ones, and we should be careful about all these associated features in the larger ones. The smaller ones usually will pass off without any problems. Then sometimes it may be associated with fetal abnormalities like vascular anomalies in the fetus, like skin hemangiomas, single umbilical artery. Then there may be abnormal cord insertion, velamentous insertion may be there, and rare cases there may be chromosomal abnormalities. Usually chorioangiomas are not known to be associated with congenital anomalies, but yes, there may be a possibility. Now, the significance of Doppler we've already discussed. I've already told you that higher the vascularity, more are the chances of the complications, and I've already told you why the complications will occur because of high vascularity. And one important part here is that despite, just now I told you that a large chorioangioma may lead to IUGR. Now, in such cases of IUGR, where the IUGR is associated with chorioangioma, there may be a false reading on Doppler. Why? Because the channels are very much enlarged. The vascularity of the placenta is quite good. So you may get normal Doppler flows, despite the fact that there is IUGR, despite the fact that the baby is not getting proper blood supply. The vascular resistance in the umbilical circulation may remain low, and this may create issues. Like you may think, that why IUGR is there, but still everything's looking normal. Then, what are the things that you should keep up in mind? You should always look out for anomalies. I've already told you, though there are very less common chances that chorioangiomas will be associated with anomalies. Fetal karyotyping may be done, as some cases may show chromosomal abnormalities. And the most important part is that do a regular follow-up scan to look for the size of the chorioangioma and development of polyhydramnios or hydrops, because these are the things that will create issues. Right, this increase in size is not a good thing in chorioangioma. Fine, so that is all that you need to be knowing about chorioangioma. The most important thing is that comes out of this lecture is that whenever you are looking at the placenta, see the placenta in its entirety. Full placenta should be seen from one end to the other end. Follow it properly, see the retroplacental area, see the placental surface. Examine the whole placenta carefully to look out for any abnormality in the placental texture. I hope this would be helpful for you. Thank you very much.